Explain how the structure of the epidermis contributes to its role as a barrier to pathogens. Answer: the epidermis is the outermost layer of the skin essential for protecting the body from pathogens. It is primarily composed of keratinocytes, which produce keratin, a tough protein that helps form a waterproof barrier. The stratum corneum, the outermost layer of the epidermis, consists of flattened, dead keratinocytes embedded in a lipid matrix. This structure creates an effective physical barrier, preventing water loss and microbial penetration. Additionally, the acid mantle, a slightly acidic layer on the skin surface, further inhibits pathogen growth. The epidermis also houses Langerhans cells, which are part of the immune system. These cells act as antigen-presenting cells, detecting foreign invaders like bacteria and viruses. They activate the immune response by signaling T cells. The tightly packed nature of epidermal cells, combined with this immune response, forms a first line of defense against infection. When the epidermis is damaged, e.g., by abrasions or burns, the barrier function is compromised, increasing the risk of infections and dehydration. This is why maintaining the integrity of the epidermis is critical in wound care to prevent secondary infections and promote healing. During the inflammatory phase of wound healing, what key cellular events occur, and how do they facilitate subsequent healing stages? Answer: the inflammatory phase of wound healing is critical for initiating repair. The first event is hemostasis, where platelets aggregate at the wound site, forming a clot that prevents further bleeding. The clot also releases growth factors like platelet-derived growth factor (PDGF), which begins the healing process. As inflammation sets in, vasodilation occurs, increasing blood flow and allowing immune cells to reach the wound. This is essential for fighting infection and cleaning the wound. Neutrophils are the first responders, arriving within hours of injury. They phagocytize pathogens and debris. Later, macrophages take over, clearing dead cells and secreting cytokines such as vascular endothelial growth factor (VEGF), which promotes angiogenesis, new blood vessel formation. These macrophages also release growth factors to support the next phase of healing, granulation tissue formation. The inflammatory phase sets the foundation for the proliferative phase, as it cleanses the wound and promotes new tissue formation. However, excessive or prolonged inflammation can impair healing, which is why managing inflammation through proper wound care is essential. Describe the process and tools used to measure the size of an irregularly shaped wound. Answer: measuring the size of an irregular wound requires accuracy and consistency to track healing over time. The first step is to document length, width, and depth of the wound. For length, the longest distance from head to toe should be recorded. Similarly, the width is measured at the widest point perpendicular to the length. Depth can be measured using a sterile cotton-tipped applicator or probe inserted into the deepest part of the wound with measurement against a ruler. For irregularly shaped wounds, traditional linear measurements may not be sufficient. In these cases, tools like transparent wound tracings can be used. A clear, sterile film is placed over the wound and its outline is traced to obtain an accurate representation of the wound's size and shape. These tracings can later be measured to calculate area. Additionally, digital planimetry uses specialized software to map and measure the wound's area more accurately. This method is useful for wounds with complex shapes, offering precise measurements. By documenting wound size regularly, healthcare providers can assess the effectiveness of treatments and track healing progress. Wound size and shape also influence dressing selection, making these measurements essential for proper care. Mrs. Taylor, a 65-year-old diabetic patient, reports severe pain during wound dressing changes. Her wound is a stage II diabetic ulcer with significant exudate. What strategies can be employed to address her pain while maintaining wound care efficacy? Answer: in this case, addressing pain while managing the stage II diabetic ulcer requires a multifaceted approach. First, pre-medication can significantly reduce pain during dressing changes. Administering an analgesic such as acetaminophen or a low-dose opioid about 3-60 minutes before the procedure will help manage pain levels. Second, using non-adherent dressings is crucial. Materials like silicone-coated or hydrocolloid dressings minimize trauma to the wound bed upon removal, reducing discomfort. Next, moist wound healing is essential in this scenario. Keeping the wound bed moist by using appropriate dressings such as hydrocolloids or alginates can decrease pain by preventing nerve endings in the wound from being exposed to air. This also accelerates the healing process by maintaining an optimal environment for tissue regeneration. For controlling exudate, highly absorbent dressings like foam or alginate dressings should be used. These help manage moisture while also reducing pain associated with excessive wetness. Finally, consider using topical analgesics such as lidocaine gel if appropriate, or explore the use of negative pressure wound therapy, which can help reduce pain by removing excess fluid and promoting tissue regeneration. A wound exhibits slough covering 60% of its bed with moderate serous exudate. What interventions should be prioritized to promote healing? Answer: the presence of slough, yellow or white necrotic tissue and moderate serous exudate requires targeted interventions. The first priority is debridement to remove necrotic tissue as it hinders healing by preventing granulation tissue formation. Enzymatic debridement using products like collagenase is effective for managing slough. Alternatively, autolytic debridement using moisture-retentive dressings, e.g. hydrocolloids, can promote the body's natural process of breaking down dead tissue. If the slough is extensive, sharp debridement may be necessary, typically performed by a healthcare professional. Next, managing the exudate is crucial. Moderate exudate requires highly absorbent dressings like foam or alginate dressings, which help keep the wound bed moist while preventing maceration of the surrounding skin. The wound's moisture balance is vital for healing, as excessive exudate can impede epithelialization. In cases of infection, antimicrobial treatments should be considered, especially if signs of infection are present, e.g. increased erythema, warmth, or purulent discharge. Topical antibiotics or antimicrobial dressings can be used, but care must be taken to avoid overuse to prevent resistance. How does chronic exposure to moisture compromise the skin barrier and increase the risk of wounds? Answer: chronic exposure to moisture leads to maceration, where the skin becomes excessively hydrated and soft. This process breaks down the skin's natural barrier by disrupting the lipid matrix in the strobum corneum, reducing its ability to act as an effective shield against pathogens and irritants. As a result, the skin becomes more fragile and susceptible to abrasions and frictional injuries. Prolonged moisture exposure also increases the risk of infection. The moist environment fosters the growth of bacteria, fungi, and other microorganisms, particularly in areas such as the perineum, which are prone to incontinence-related moisture. This environment can lead to conditions like diaper dermatitis or pressure ulcers. Furthermore, macerated skin is more likely to break down when subjected to external stresses such as pressure or friction. This is why maintaining the skin's integrity through regular cleansing, application of moisture barriers, and management of incontinence is essential in wound prevention. Moisture-absorbing dressings like superabsorbent polymer dressings can help manage moisture around wounds, promoting healing and protecting the surrounding skin. Distinguish between stage II and stage II pressure ulcers and their implications for treatment. Answer: stage II pressure ulcers involve partial thickness loss of skin affecting the epidermis and sometimes extending into the dermis. The wound presents as a shallow open ulcer with a pink or red wound bed, or as a ruptured blister filled with clear fluid. There is no necrosis or slough. Treatment focuses on maintaining a moist wound environment using hydrocolloid or foam dressings, which promote healing and protect the wound from further injury. Pressure relief and offloading are crucial to prevent worsening. Stage II pressure ulcers are more severe, involving full-thickness tissue loss that extends into the subcutaneous tissue, potentially exposing fat. The wound may have slough or necrotic tissue and may exhibit undermining or tunneling. Treatment requires debridement, sharp enzymatic or autolytic to remove necrotic tissue, followed by the application of moisture-retentive dressings and appropriate absorbent products to manage exudate. Surgical intervention may be required for deeper wounds. Nutritional support is also critical at this stage to promote wound healing and prevent infection. Stage II ulcers require more intensive care and can lead to significant complications, including infection and sepsis, making early detection and aggressive management essential. What are the main risk factors for developing pressure ulcers in hospitalized patients, and how can these be mitigated? Answer: the primary risk factors for developing pressure ulcers include immobility, moisture, poor nutrition, and increased pressure on specific body areas. Patients who are bedridden or have limited mobility are at higher risk, as they cannot reposition themselves frequently to relieve pressure on vulnerable areas such as the sacrum, heels, and hips. Moisture from incontinence or perspiration increases the likelihood of skin maceration, which compromises the skin's barrier function and leads to ulcer formation. Poor nutrition, particularly inadequate protein intake, impairs tissue repair and decreases the skin's resilience to external stresses. To mitigate these risks, healthcare providers should implement regular repositioning schedules, typically every 2 hours, to alleviate pressure. Using specialized support surfaces like foam mattresses or pressure-relieving cushions can reduce the risk of pressure buildup. Keeping the skin clean and dry is essential, and moisture barrier creams can be used to protect at-risk areas. Nutritional support, including a diet rich in proteins, vitamins, and minerals, is essential for optimal healing and skin health. Regular skin assessments should also be conducted to detect early signs of pressure damage. What are the psychological effects of chronic wounds, and how can healthcare providers address these concerns? Answer: chronic wounds, such as diabetic ulcers or venous leg ulcers, often lead to significant psychological distress for patients. Pain, restricted mobility, and the visible nature of the wound can contribute to anxiety, depression, and social isolation. Patients may feel self-conscious about the appearance of the wound, especially if it affects prominent areas like the legs or face. The uncertainty about healing outcomes can also lead to feelings of hopelessness or frustration, as the prolonged nature of chronic wounds often undermines the patient's sense of control. Furthermore, the chronicity of the condition can interfere with daily activities and quality of life, leading to a reduction in the patient's overall well-being. Healthcare providers should address these concerns by offering both physical and emotional support, providing clear, realistic expectations for wound healing, while celebrating small improvements can help mitigate feelings of helplessness. Pain management, patient education, and psychological counseling may be needed to reduce emotional burden. Referrals to wound care specialists and involvement in support groups can also provide additional support for patients coping with the emotional aspects of living with a chronic wound. Explain the significance of biofilm formation in chronic wounds and its impact on treatment strategies. Answer: biofilm formation in chronic wounds is a significant challenge to healing. Biofilms are clusters of bacteria encased in a protective matrix that adheres to the wound surface. This matrix shields the bacteria from the body's immune response and makes them less susceptible to antibiotics. In chronic wounds, biofilm can prevent proper granulation, tissue formation, and epithelialization, essential processes for wound closure. The bacteria within the biofilm can produce toxins, leading to further tissue damage and inflammation. Biofilms also impede the action of standard dressings and topical antibiotics, which are less effective in penetrating the biofilm structure. Addressing biofilm requires targeted treatments. Debridement, either enzymatic or sharp, can physically remove the biofilm, allowing antibiotics or antimicrobial dressings to be more effective. Topical antiseptics, such as silver sulfadazine or honey-based dressings, can disrupt biofilm integrity and reduce bacterial load. Additionally, negative pressure wound therapy has been shown to help eliminate biofilms by creating a dynamic environment that promotes tissue regeneration while removing excess fluid. What are the key challenges in diagnosing biofilm-related infections in chronic wounds, and how can advanced diagnostic techniques improve patient outcomes? Answer: biofilm-related infections in chronic wounds are challenging to diagnose due to their unique characteristics, complex structure. Biofilms are composed of microbial communities encased in an extracellular polymeric substance EPS matrix, making them resistant to standard cultures. Polymicrobial nature: biofilms often consist of multiple bacterial species, complicating the identification of pathogens. Dormant bacteria: some bacteria within biofilms are metabolically inactive, making them harder to detect using traditional methods. Advanced diagnostic techniques such as molecular diagnostics, techniques like polymerase chain reaction (PCR) or next-generation sequencing (NGS) can identify a broad range of microbes, including those in dormant states. Fluorescence in situ hybridization (FISH) enables visualization of biofilms in tissue samples, aiding in precise identification. Microscopy, electron or confocal laser scanning microscopy provides structural details of biofilms. These approaches improve outcomes by enabling targeted antimicrobial therapy, reducing empirical antibiotic use, and aiding in the effective debridement of biofilms. This aligns with antibiotic stewardship principles and promotes optimal wound healing. Explain the differences between incontinence-associated dermatitis, IAD, and pressure injuries. Why is differentiation critical in clinical practice? Answer: incontinence-associated dermatitis, IAD, and pressure injuries are distinct conditions, though they can coexist. Etiology: IAD is caused by prolonged exposure to moisture, urine, or feces, leading to skin maceration and irritation. Pressure injuries result from sustained pressure, shear, or friction, impairing blood flow and causing ischemia. Location: IAD typically affects perineal, buttock, and inner thigh regions. Pressure injuries occur over bony prominences like the sacrum, heels, or hips. Appearance: IAD presents as diffuse redness with possible erosion. Pressure injuries are well defined and may involve deeper tissue damage, including ulcers. Differentiation is critical because treatment strategies differ. IAD focuses on moisture control and barrier protection using creams or films. Pressure injury management emphasizes pressure redistribution. G. Specialized mattresses and debridement if needed. Adhering to Wound Ostomy and Continence Nurses Society WOCAN guidelines ensures accurate diagnosis and tailored interventions. Maria, a nurse in a long-term care facility, notices that an 82-year-old resident, Mr. Samuel, has persistent redness and skin breakdown in the folds of his abdomen. The area feels warm to the touch and has a faint musty odor. Despite using standard cleaning and drying protocols, the condition persists. What should Maria suspect, and what interventions would best address Mr. Samuel's condition? Answer: Maria should suspect intertriginous dermatitis, a condition often caused by moisture, friction, and microbial overgrowth in skin folds. Key indicators: warm, moist environment promoting fungal or bacterial growth. Odor suggests possible secondary infections such as Candida albicans. Interventions: skin hygiene, regularly clean and dry the area using non-irritating cleansers. Topical agents: apply antifungal creams. G. Clotrimazole if fungal infection is confirmed. Barrier creams or zinc oxide preparations can protect against further irritation. Moisture management: use moisture-wicking textiles or dressings. G. Foam or hydrocolloid dressings. Reduce friction. Positioning devices or absorbent materials can minimize rubbing. Maria should consult a physician for further evaluation and implement a skincare protocol tailored to ITD, following facility guidelines. What role does antibiotic stewardship play in the management of chronic wounds, and what strategies can nurses use to adhere to its principles? Answer: antibiotic stewardship aims to optimize the use of antibiotics to combat resistance and improve patient care. Role in chronic wounds: prevents misuse of antibiotics in wounds with bacterial colonization, non-infected. Ensures appropriate therapy for wound infections, avoiding overuse or underuse. Nursing strategies: accurate assessment. Distinguish between colonization and infection based on clinical signs, e.g., erythema, purulence, systemic symptoms. Cultures and sensitivity testing. Collect appropriate samples before initiating antibiotics to guide therapy. Patient education. Counsel on proper antibiotic use and adherence. Collaboration. Work with interdisciplinary teams to monitor treatment efficacy. Adherence to CDC and WHO antibiotic stewardship guidelines is critical in reducing resistance and enhancing chronic wound care outcomes. Explain the physiological mechanisms behind moisture-associated skin damage, MAST, and outline prevention strategies. Answer: MASD occurs due to prolonged exposure to moisture. G. Sweat, urine, feces, leading to skin maceration, softening and weakening of the stratum corneum. Increased pH. Alkalinity disrupts the skin barrier, promoting bacterial or fungal colonization. Friction sensitivity. Moist skin is more prone to damage from movement or rubbing. Prevention strategies. Moisture management. Use absorbent pads, breathable garments or containment systems. Barrier products. Apply skin protectants like silicone-based creams. Skincare protocols. Cleanse the skin gently and avoid harsh soaps. Positioning. Reposition immobile patients frequently to reduce pressure and friction. These measures align with NPI-AP guidelines for preventing MASD and maintaining skin integrity. What are the primary differences between bacterial colonization and infection in wound care, and why is this distinction important? Answer: bacterial colonization refers to the presence of bacteria in a wound without causing harm or symptoms, while infection occurs when bacteria invade tissue, multiply, and cause clinical symptoms like increased redness, warmth, purulence, or systemic effects, fever, malaise. In colonization, bacteria exist without disrupting the wound healing process, meaning they are not actively causing tissue damage. Infection, on the other hand, triggers an inflammatory response and can delay wound healing, increase pain, and introduce systemic complications if untreated. The distinction is crucial for treatment decisions. Colonization often requires no intervention beyond regular wound care, whereas infection may necessitate targeted antimicrobial therapy, either systemic or topical, based on culture and sensitivity results. Overuse of antibiotics for colonized wounds can contribute to antibiotic resistance and other complications. Clinicians must use clinical signs, e.g., increased exudate, change in wound appearance, and laboratory tests, e.g., wound cultures, to differentiate between these two states. Discuss the clinical and ethical considerations in using advanced diagnostics for chronic wound biofilms. Answer: using advanced diagnostic techniques for chronic wound biofilms, such as PCR or fluorescence in situ hybridization, FISH offers clinicians an opportunity to accurately identify biofilm-related infections and tailor treatment. However, ethical considerations must be taken into account. Clinically, biofilms are notoriously difficult to detect with standard wound cultures, making advanced diagnostics essential for identifying persistent infections. Molecular methods can identify difficult-to-culture organisms, potentially improving patient outcomes by ensuring appropriate and targeted antimicrobial therapy. However, these methods can be expensive and may not always be readily available in all healthcare settings. Clinicians must weigh the cost and practicality of advanced diagnostics against the potential benefits, especially in resource-limited environments. Ethically, there is a responsibility to ensure patient consent for invasive diagnostic procedures, explaining potential risks and benefits. Additionally, privacy and confidentiality must be upheld when handling sensitive patient data. A patient with a peristomal wound develops irritation and maceration despite regular appliance changes. What should the nurse prioritize in addressing this complication? Answer: in this scenario, the nurse should prioritize moisture management and skin protection. Peristomal skin irritation and maceration are common complications in patients with ostomies, often caused by prolonged exposure to stool, urine, or moisture from leakage. First, the nurse should assess the stoma appliance for proper fit and positioning, as an ill-fitting appliance can cause leakage and irritation. Ensuring that the seal is intact and the appliance is securely adhered to the skin is critical. Next, skin care must be optimized by gently cleansing the affected area with a mild cleanser and avoiding harsh scrubbing. Applying a protective barrier such as a skin sealant or paste can help protect the skin from further irritation. If maceration is present, a hydrocolloid dressing or foam dressing may be used to absorb excess moisture and provide a protective layer. The nurse should also assess the patient's nutritional status, since poor nutrition can impair wound healing and skin integrity. Collaboration with a wound care specialist or stoma therapist may be necessary if the condition persists. Prompt intervention is key to preventing further complications and improving the patient's quality of life. Analyze the impact of polypharmacy on wound healing in elderly patients and suggest best practices for management. Answer: polypharmacy, or the use of multiple medications, is common in elderly patients and it can significantly impact wound healing. Certain medications can interfere with circulation, immune response, and tissue regeneration, leading to delayed or impaired wound healing. For instance, corticosteroids reduce the inflammatory response and suppress collagen synthesis, slowing healing. Anticoagulants increase the risk of bleeding and hematoma formation, making it harder for wounds to close properly. Immunosuppressants can increase the risk of infections, further complicating wound healing. Best practices for managing polypharmacy in elderly wound care include comprehensive medication review. Assess all medications the patient is taking and discuss potential drug interactions with the healthcare provider. Monitor for side effects. Regularly evaluate wound healing progress and watch for signs of medication-related complications, e.g. infection, delayed healing. Collaboration with healthcare providers. Engage with pharmacists and the prescribing physician to adjust medications or switch to alternatives when appropriate. Patient education. Ensure that the patient and caregivers understand the impact of medications on wound care and healing processes. Describe the role of interdisciplinary teams in managing moisture-associated skin damage, MAST, and improving patient outcomes. Answer: moisture-associated skin damage, MAST, occurs when the skin is exposed to prolonged moisture, often from incontinence or excessive sweating, leading to irritation, maceration, and breakdown. Managing MASD requires a collaborative approach involving an interdisciplinary team to ensure optimal care and outcomes. The key members of the team include nurses. Nurses assess the skin, implement moisture management strategies, e.g. absorbent products, skin protectants, and monitor for complications. They are central to patient education on skin care and hygiene. Physicians diagnose underlying conditions contributing to MASD, e.g. incontinence or excessive sweating, and prescribe necessary treatments or medications. Dietitians assess the patient's nutritional status, as poor nutrition can impair skin integrity and healing. They may recommend dietary adjustments to improve skin health. Physical therapists. If immobility is contributing to the development of MASD, physical therapists may recommend positioning strategies to reduce pressure and prevent skin breakdown. Wound care specialists. These specialists provide expertise in advanced wound care and recommend appropriate dressings, barriers, or therapies to manage MASD effectively. Interdisciplinary collaboration ensures that all aspects of MASD management, such as moisture control, skin protection, nutrition, and mobility, are addressed holistically, improving patient outcomes. Regular communication and shared care plans lead to more efficient, patient-centered treatment. What are the primary differences between hydrocolloid dressings and foam dressings in wound care, and in which clinical scenarios would each be most appropriate? Answer: hydrocolloid and foam dressings serve different purposes in wound management. Hydrocolloid dressings. Composition. Hydrocolloids consist of gel-forming agents like pectin or gelatin combined with an adhesive layer. Indications. Suitable for shallow to moderately exudating wounds such as pressure ulcers. Stage I Roman throwing can maintain a moist wound environment to promote autolytic debridement. Advantages. They are occlusive, reducing bacterial contamination, and are ideal for wounds requiring insulation and protection against shear forces. Limitations. Not suitable for heavily exudating or infected wounds due to their limited absorptive capacity. Foam dressings. Composition. Made of hydrophilic polyurethane foam, often with an adhesive border. Indications. Best for moderately to heavily exudating wounds like venous leg ulcers or diabetic foot ulcers. Advantages. Highly absorptive, provide cushioning, and allow gas exchange while blocking microorganisms. Limitations. Require secondary dressings in some cases and may not conform well to certain wound shapes. Clinical scenarios. Hydrocolloids. A patient with a clean, shallow pressure ulcer at risk for friction would benefit most. Foams. A patient with a venous ulcer producing heavy exudate would require foam dressings for adequate absorption. Explain how negative pressure wound therapy promotes wound healing. Include the physiological principles involved. Answer. Negative pressure wound therapy promotes wound healing through several mechanisms. Microstrain effect. Negative pressure applies mechanical forces to the wound bed, causing cellular deformation. This stimulates fibroblast proliferation and promotes granulation tissue formation. Exudate management. NPWT removes excess wound fluid, reducing maceration of periwound tissue and bacterial burden. Enhanced perfusion. The subatmospheric pressure improves capillary blood flow in the wound bed, enhancing oxygen and nutrient delivery. Reduction of edema. By removing interstitial fluid, NPWT reduces localized swelling and creates an environment conducive to healing. Protection from contamination. A sealed dressing minimizes external contamination and prevents infection. Clinical evidence. Studies have shown that NPWT significantly reduces healing time in wounds such as post-surgical dehiscence, traumatic injuries, and chronic ulcers. Mr. Gonzalez is a 55-year-old patient with diabetes mellitus. He presents with a non-healing ulcer on his left foot. The ulcer measures 3 cm x 2 cm with moderate exudate and a necrotic core. What advanced wound care strategies should the nurse consider for Mr. Gonzalez, and why? Answer. The nurse should consider the following strategies. Debridement. Perform sharp or enzymatic debridement to remove necrotic tissue, which acts as a barrier to healing. Topical agents. Use antimicrobial agents e.g. silver or iodine-based dressings to reduce bioburden and prevent infection. Advanced dressing. Select foam dressings to manage moderate exudate while maintaining a moist wound environment. Adjunct therapy. Consider NPWT if the wound does not progress after initial debridement and dressing changes. NPWT would help manage exudate and promote granulation. Systemic management. Ensure optimal glycemic control and manage systemic factors like vascular insufficiency. Rationale. Diabetes impairs wound healing due to microvascular damage, making these interventions critical. Why is hyperbaric oxygen therapy (HBOT) recommended for certain chronic wounds, and what contraindications must be considered? Answer. Hyperbaric oxygen therapy (HBOT) delivers 100% oxygen at increased atmospheric pressures, enhancing wound healing through oxygenation of hypoxic tissues, promotes angiogenesis and collagen synthesis in poorly vascularized areas. Bactericidal effects. Hyperoxia inhibits anaerobic bacterial growth and boosts leukocyte activity. Reduction of inflammation. HBOT reduces cytokine-mediated inflammation and edema. Indications. Chronic diabetic foot ulcers, especially Wagner grade IB or higher, radiation-induced necrosis, non-healing surgical wounds. Contraindications. Untreated pneumothorax, absolute contraindication, concurrent use of certain chemotherapeutic agents e.g. bleomycin, severe claustrophobia. Describe the pharmacological differences between topical and systemic pain management in wound care. Provide examples of each. Answer. Topical pain management. Mechanism. Delivers medication directly to the wound site, reducing systemic exposure. Examples. Lidocaine gel reduces procedural pain during dressing changes. NSAID-containing creams address localized inflammation. Advantages. Minimizes systemic side effects and allows precise targeting. Limitations. Ineffective for deep or generalized pain. Systemic pain management. Mechanism. Medications act through systemic circulation to address both local and widespread pain. Examples. Acetaminophen for mild pain. Opioids like morphine for severe or procedural pain. Advantages. Suitable for severe or chronic pain beyond localized wounds. Limitations: risk of systemic side effects like sedation or gastrointestinal distress. MS. Clark is undergoing dressing changes for a venous ulcer and experiences severe procedural pain. What non-pharmacological interventions should be implemented to improve her comfort during these procedures? Answer: non-pharmacological interventions include distraction techniques, use music therapy or guided imagery during dressing changes, temperature modulation, warm solutions to body temperature to reduce discomfort, cognitive behavioral therapy (CBT), teach relaxation techniques or breathing exercises, pressure reduction, use non-adherent dressings to minimize trauma during removal. These methods are endorsed by guidelines from organizations like the European Wound Management Association (EWMA) for reducing pain without pharmacological reliance. What are the physiological benefits of using alginate dressings in the management of exudating wounds, and in which specific types of wounds would these dressings be most beneficial? Answer: alginate dressings are derived from seaweed and are known for their high absorbent properties, making them highly beneficial in managing exudating wounds. The physiological benefits include exudate absorption. Alginate dressings form a gel when they come into contact with wound exudate, which helps to maintain a moist wound environment while absorbing large amounts of fluid. This is crucial in preventing maceration of surrounding skin. Hemostasis. Alginate has the ability to promote hemostasis by absorbing fluid from the wound bed and helping to control minor bleeding. This is especially useful in wounds with light to moderate bleeding, such as in venous leg ulcers. Autolytic debridement. The gel-like consistency created by the alginate dressing assists in autolytic debridement by softening necrotic tissue, facilitating its removal without the need for sharp debridement. Protection from infection. By maintaining a moist environment, alginate dressings can reduce the risk of infection by creating a barrier that prevents external contaminants from reaching the wound. Indications: venous ulcers. These wounds often produce heavy exudate, making alginate dressings ideal for managing fluid. Diabetic foot ulcers. With moderate to heavy exudate and potential for infection, alginate dressings help manage both issues. Pressure ulcers. Stage III and IV wounds that require high absorptive capacity. Clinical guidelines. National Institute for Health and Care Excellence (NICE) recommends alginate dressings as first-line therapy for managing exudating wounds with necrotic tissue or excessive fluid. Explain the role of growth factors in wound healing and discuss the key types of growth factors used in modern wound care therapies. Answer: growth factors are proteins that regulate various stages of wound healing, such as inflammation, tissue proliferation, and remodeling. They play a crucial role in accelerating wound healing by stimulating the migration and proliferation of cells involved in tissue regeneration. The primary types of growth factors used in wound care include platelet-derived growth factor (EDF). PDGF is essential for the early stages of wound healing, promoting endothelial cell migration, collagen synthesis, and angiogenesis. It is commonly used in chronic, non-healing wounds like diabetic foot ulcers and venous ulcers. Epidermal growth factor (EGF) promotes keratinocyte proliferation and migration, facilitating epithelialization of the wound surface. It is used in wounds requiring rapid reepithelialization, such as burns or surgical wounds. Transforming growth factor beta (TGFB). TGFB regulates the later stages of wound healing, such as collagen production and the remodeling phase. It is useful for promoting fibrosis and scar tissue formation in deeper wounds or those requiring structural support. Fibroblast growth factor (FGF). FGF stimulates fibroblast activity, enhancing collagen formation and angiogenesis, which is particularly useful for deep wounds that need vascularization and tissue regeneration. Mr. Patel is a 68-year-old patient with a history of chronic venous insufficiency. He has developed a large, shallow venous ulcer on his lower leg with moderate exudate. Despite frequent dressing changes, the ulcer shows no signs of healing. What advanced wound care strategies should the nurse consider to improve Mr. Patel's wound healing and prevent further complications? Answer: the nurse should consider the following advanced wound care strategies. Compression therapy. Chronic venous ulcers are often caused by venous insufficiency, and compression therapy using bandages or compression stockings is the cornerstone of treatment. It helps to reduce edema, promote circulation, and enhance wound healing. Clinical guidelines from the Society for Vascular Surgery (SVS) recommend compression as the first-line treatment for venous ulcers. Debridement. For non-healing ulcers with necrotic tissue, sharp or enzymatic debridement should be performed to remove devitalized tissue, facilitating healing. This will help the wound bed be more conducive to healing and prevent bacterial contamination. Advanced dressings. Given the moderate exudate, foam dressings or hydrocolloids can be used. These dressings absorb exudate effectively while maintaining a moist wound environment which supports autolytic debridement and reduces bacterial growth. Topical agents. Consider using antimicrobial dressings, e.g., silver or iodine-based, to address potential bacterial contamination and prevent infection, particularly if signs of infection are present. Discuss the advantages and disadvantages of using silver-based dressings in wound care. Answer. Silver-based dressings are widely used in wound care for their antimicrobial properties. They are particularly effective in managing infected or at-risk wounds. Advantages. Antimicrobial action. Silver has broad-spectrum antimicrobial activity against a range of pathogens, including MRSA, Pseudomonas aeruginosa, and Enterococcus. It helps in reducing bioburden and preventing infection, which is crucial in chronic and complex wounds. Reduce biofilm formation. Silver has been shown to reduce biofilm formation, which is common in chronic wounds, thereby improving the effectiveness of wound healing. Maintaining a moist wound environment. Many silver dressings are designed to maintain a moist wound environment, which is essential for promoting faster healing and autolytic debridement. Evidence-based. Several clinical studies and guidelines, such as those from the Wound Healing Society, publisher, endorse the use of silver-based dressings for infected or critically colonized wounds. Disadvantages. Cost. Silver-based dressings are generally more expensive than non-silver alternatives, which may be a concern in long-term care. Cytotoxicity. Prolonged use of silver-based dressings can sometimes lead to cytotoxic effects, particularly on healthy granulation tissue. This can impair wound healing in some cases. Silver resistance. Overuse or inappropriate use of silver dressings may contribute to the development of silver resistance, limiting their future efficacy. Clinical guidelines. The National Institute for Health and Care Excellence (NICE) suggests that silver dressings should be used only when there is clinical evidence of infection or when wounds are critically colonized, and not as a routine dressing choice.